and we're going to be looking at compartment syndrome, which is something really, really important to us to know and understand as far as our orthopaedic patients go. I'm Wendy and I'm part of the WA chapter of ANZONA, and I'm Publicity Officer at the moment for the ANZONA committee. All right, what we're having a look at with compartment syndrome, and I'm just waiting for the next slide to click through, is compartments, and particularly a lot of what we're going to be looking at today, I'll be giving lower limb as an example, because that's quite often where we are seeing compartment syndrome within our orthopaedic patients. Basically, a compartment is when you've got a fascia surrounding muscle and also your nerves and blood supply travelling through that compartment, and it's a thick tensile a structure made of collagen that it's surrounding, and it doesn't really expand very much when there's extra volume or pressure that's within that compartment. So what it leads to is a compromise in our circulation, which then ends up affecting our nerves and also the muscles that are within that compartment through inadequate tissue oxygenation from happening. Right, there's 3 different types of compartment syndrome, and what we'll do is we'll just identify those. First of all, there's classified by incipient compartment syndrome, and that's where this is probably what we're mostly seeing within our orthopaedic wards, and I think we're really quite good at identifying and doing something about it and preventing compartment syndrome from going any further. So what it is it's an impending compartment syndrome. We're picking up that there's something that's not quite right within your vascular status. It's likely to develop into a full-blown compartment syndrome unless we intervene and put measures in place to prevent it. And as I say, I think that's something that in orthopaedics we luckily do really quite well. Other times we'll see an acute compartment syndrome when the injury or condition causes a prolonged elevated interstitial tissue pressure and they go into that full-blown compartment syndrome. Where I've seen this is patients have actually been admitted and they're already in compartment syndrome, or someone's come back to theatre post-operatively. We haven't picked up that incipient compartment syndrome that's starting to develop, and then it goes into your full-blown acute compartment syndrome. The other thing that we do see, and we don't necessarily see this on inpatients, but certainly out in the community, people are seeing it, and that's a chronic or an exertional compartment syndrome, where you've got your people, they're exercising, they're complaining of, they might be describing it as shin splints, where they're getting a temporary increase in pressure within those compartments while there's the muscle activity. And again, it tends to be your people that are really quite fit, doing quite a lot of exercise as well, getting that bulk and that increase within their muscles, and that's causing a lot of tightness within the compartments. So when they're exercising, they're getting that rise in pressures and a lot of pain from that as well. What we're going to be dealing with today is, because we're most of us are from the hospital and inpatient settings, we'll be talking about the incipient and the acute, and we'll leave the chronic because we are unlikely to see that. Oh, sorry, I've just gone a bit too far forward. When we do see our compartment syndromes, it's most likely involves the leg, and particularly any injuries around the tibia. We see it below knee, that we're seeing it from happening, because that's where our fascia tend to be really quite tight and they don't have a lot of room to move within them. And the other place that's quite common in an inpatient setting is within the forearm. It can also affect compartments throughout the rest of our body because we've got lots of them, and that can include the hand, within the foot, shoulder, thigh, buttock, and there's also abdominal compartment syndrome as well. As we can see, surrounding our lower leg, and this is looking through a cross-section, which is looking through our tibia and fibula, we can see that there's several compartments within there. We have got, over here, our anterior side, we have our posterior compartments. We've also got a lateral and also a deep posterior compartment there as well. Okay, and travelling through there, we can see our blood supply and also our nerves. And we can see how if there's an increase in volume for any reason and an increase in pressure, how easy it is to shut down that blood supply and cause neurovascular compromise to the patients. The sort of causes that we see within our orthopaedic patients is, and where we need a high level of suspicion, is patients that are coming in with closed fractures. The reason we say closed and not open is your open fractures are much less likely to see it, because as those fracture fragments are coming through and making that an open fracture, they're also slicing through the fascia, and they've done a fasciotomy from the inside for you. So it can happen with some of the compartments that are adjacent to the area, but the actual area of fracture, that fascia is sitting there nice and open and letting that pressure out. Not that we're wishing open fractures on people, but certainly closed fractures is where we should have a higher level of suspicion. Can also be without a fracture, so any severe soft tissue injuries, anything that's been causing compression of a limb, or causing lots of swelling. If there's lots of edema, again, keep your level of suspicion high. Crush injuries in particular, because what's happening is while that crushing pressure is there, that blood supply may have been closed down to within that compartment. And when we look at the pathophysiology, we'll see about all of the histamine release that happens at that time that creates a whole lot of extra edema that's happening within that area, that's filling up that compartment and putting the pressures up. Anything that's constricted from the outside of the limb as well may be the cause, such as tight plasters. And one of the ones that we actually see quite commonly, and what I've probably seen the most of, is when a patient has been in a drug-induced state out in the community, they've maybe lost consciousness, they've had a limb that's been pinned under their body for some time, and lost the blood supply to that area and have sent themselves into compartment syndrome within that too. And I'm sure that some of us have seen patients that have been admitted after that with a compartment syndrome. There's quite a few several possible mechanisms that cause it from happening. First of all, if there's anything that we causes a decrease in the actual size of the compartment. So as we see from external things such as putting on tight dressings, that are circumferential style dressings are particularly putting limbs at risk, or casts that are too tight, or casts that are fitting fine and then a limb that swells from underneath it. Any localized external pressure, or also when we're putting traction on, and if we're putting a little bit too much weight on that traction, we're distracting out and we're over distending that compartment. That will stretch it but reduce the volume within that compartment, and that can cause problems with the pressure. Anything for any reason that increases the content of the compartment, so that's when the bleeding into the area, the edema, a vascular injury, or also with our IV infusions, if that's infiltrating within that compartment, for example, within the forearm, that's also another cause of compartment syndrome that we may see. Things that are happening within the body that is causing an increase in the capillary permeability within that compartment, such as post-ischemic swelling, exercise when we're looking at that chronic compartment syndrome, seizure, trauma, burns, and also orthopedic surgery that will increase that permeability and therefore increase the volume within that as well. And increased capillary pressure, such as a venous obstruction, will also cause compartment syndrome. So what we're going to do is we'll look at the pathophysiology behind it and what actually causes the problems. First of all, as we know, fascia forms a really confined space for muscles, blood vessels, and nerves. Some of the compartment syndromes in our body have a little bit more room to move, and as we've already identified, particularly around the tibia, some of the compartments are very, very tight with not much movement at all. If for any reason we have an increased fluid accumulation or an external compression, this leads to an increase within the pressure within that compartment. That pressure, because the fascia is tight, has nowhere to go expanding outwards. So what it does is that pressure is then exerted on the blood vessel walls, squeezing them shut, because like anything, they've got to stop getting volume within that area, and that's the way that it will do it. Doesn't take very long to happen at all. So where we start getting the damage from that loss of the blood supply, nerves start to be damaged within about 30 minutes, and that any nerves without a blood supply, that damage will be irreversible within only 2 to 4 hours. Now you think about if you've been sitting there with your legs crossed and you've just managed to give yourself pins and needles, that can happen really quite quickly within minutes that we're starting to do it. And that's actually that very, very early signs with when we're looking at the classification of that incipient compartment syndrome. We're not going into a compartment syndrome when we do that, because all of a sudden we're recognising those pins and needles, and we're doing something to actually get that blood supply in there with banging our foot or uncrossing our legs or whatever we need to do. But the nerve damage and these signs and symptoms nerve-wise start very, very early, and they're the first signs that we're going to know that something's going on. Muscles without a blood supply can actually survive a little bit longer. So the damage will start happening to the muscles at about 2 to 4 hours. But after about 6 to 8 hours, muscles without a blood supply, the damage is irreversible. Okay, and it can't be taken back, and it can't be fixed from that stage as well. So it's permanent damage that's happening. The thing I want to show about this slide, and it's something that experienced orthopaedic nurses know, is damage is one shift. Okay, it's only one shift that if that neurovascular alteration is not picked up within just one shift, a patient can lose their limb and have a totally non-functioning limb in that. So going back to the pathophysiology, we know we've had the injury or the compression that's caused it. That's caused the edema or the bleeding within the area, and that's when we start to get that increase in pressure. Again, we know after that 2 to 4 hours, we're starting to get the muscle anoxia, and that makes the situation even worse if nothing's done to be reversing whatever's causing it. So with the muscle anoxia, we've got all of that histamine release happening, and that will make it even worse because the histamine release will start making even further leaking of interstitial fluid within that area, further increase in pressure, and it's just a spiralling downwards. Again, even more decreased tissue perfusion from that increased volume, more ischemia of our nerves and our muscles, and it's just a spiralling that keeps getting worse with that. The signs and symptoms that we're looking for is anything that's altering our neurovascular status. So all of our neurovascular obs are going to be looking for the few things. So we say the nerve damage because the nerves are the first thing that's going to let us know. And even fascia have got a whole lot of nerve receptors. So it's the decrease of blood supply to the area, but also the receptors around the fascia that are starting to let us know that something's happening. So your paresthesia and your pins and needles is a really, really good early sign that something's not right with that area. Pain is a very, very good sign and an early sign as well. And it's an unrelenting pain. It's a pain that doesn't seem to be in line with the sort of injury that the person's got. It's also a pain that's unrelieved. So if you're giving the patient narcotics or whatever pain control, and going back assessing what effectiveness that pain control has had and finding that it's not improving, again, that should be ringing warning bells, even if there are no other signs and symptoms that are there at the time, and having a look back to see what's happening. Pallor of the limb, looking at pale because we know that that blood supply is shutting down, or the other thing that we could see is a very congested looking limb as well if the vascular compromise is happening. The paresthesia, as we said, a nice early sign that with the pins and needles coming through. A later sign, because we know that the damage to the muscles is a little bit later, will be a paralysis coming through. And pulselessness, if it's there as a sign, it's a very reliable sign, obviously, that something is very, very compromised. But if you've still got pulses there, chances are that that shouldn't be suggesting that everything's okay. So pulselessness, straight away we know medical emergency with that limb. But assessing pulses and finding them there shouldn't really alter our level of suspicion that there could be something wrong. What happens is when the pressure's coming in, we know that it's at 30 milligrams of mercury, that it's enough to shut down the proper blood supply to all of that compartment. But your pulses will actually stay until the pressure within that compartment gets all the way up to your diastolic blood pressure. So if you've got someone with a diastolic of 80, those pressures within that compartment, your pulses will still keep going through until your pressures are really, really quite high, and it hopefully has been picked up before that time that there's a problem. Okay, so message, don't rely on the fact that they've got pulses to say that everything's okay, because it can be really quite compromised. So we just got a little slide here, and this was of a patient that's had a knee dislocation, but straight away we can just see that foot that's on the right hand side of your screen. And I like this slide because it shows you just the difference in colour of both the 2 feet, and straight away, we know that that's someone that's been really quite compromised neurovascularly. Patient's been admitted already in that neurovascular compromise, but hopefully within our orthopaedic patients that are on the ward, we'd be picking up that something was wrong way before it got to that sign. But it's just a lovely show of a nice limb for us to have a look at. A few important points just to hammer home. First of all, by the time all of these symptoms have developed, especially that pulselessness, the limb will be non-viable. Okay, so rely on those nice early signs, such as the pins and needles and also the pain with that. Another thing to keep in mind is all of these signs are so subjective, but they're also very hard to elicit in the unconscious patient, because obviously they're not going to be able to tell us about the pins and needles. They're not going to be able to report what's happening with their pain. If your patient's uncooperative or unable to tell you, and also regional blocks, and with our orthopaedic patients with regional blocks, that while that's all in place, it makes it a lot harder for them to tell us. So that's when our observations, as far as really looking at that limb, looking for the pallor, looking for the edema, tightness, feeling within that limb, that's where that really comes into play, and making sure that we're keeping a close eye on it while they've got a regional block, so that we're avoiding it from happening. Another unconscious patient is contractures that are happening. And this reminds me of a situation where I got called into a critical care area to have a look at someone's forearm that the nurses were suspecting compartment syndrome. And what had happened was this unconscious patient that was ventilated was unable to tell them, obviously, about those early signs that were coming through. But what they were noticing was this unusual positioning of the patient's forearm. And we can see the contractures starting from that as well. This is an shot off the internet. It's not the actual limb that I was looking at, but it reminds me very much of it. One of the things that I noticed about it, because it was quite a developed compartment syndrome that probably should have been picked up a little bit earlier, was when I felt the forearm, it was like you could have knocked on concrete. It was a really tense, hard forearm that looked really edematous, and it was the fingers coming across into this clawed position of the Volkmann contractures as well. So really having a look, assessing, feeling those limbs, particularly if the patient is unable to tell you, will really help with your assessment of them as well. So really we need that high index of suspicion and really diligent observation required to make the diagnosis with them as well. As I said, if it's pulseless, there's no point actually trying to find out what the pressure is within that compartment. Doing the striker needle and finding out your compartment pressures will cause further delays. Okay, we know that that's an emergency. They need to get into theatre, they need a fasciotomy as quick as possible, and we know that they're very, very compromised. However, if you're picking up the earlier signs and that you're not quite sure, that's where measuring of your compartment pressures really comes in handy to make a decision on, yes, this patient needs to go to theatre, or no, that this is something that we can just manage and keep a little bit of a close eye on. So identifying early is the best treatment to prevent any of that muscle and nerve damage, because you only really have half an hour to a couple of hours to preserve those nerves. Prevention, like anything within orthopedics, through elevation of our limbs after injury and post-op, is a really good way of preventing it happening. And I think, as we said earlier, because that's something that we do as orthopedic nurses really quite well, I really do believe that we are preventing a lot of it from happening within our patients. If you're suspecting it, what should you do? First of all, if it's not already, elevate the limb. And what we want to do is we want to elevate the limb up to the level of the heart. We used to elevate really high, and we used to take the limb as high as we could just about get it with being comfortable for the patient. But then they feel that the arterial pressure is compromised with getting the blood flow into that area. So if we can have it at heart level, if possible, that's the best level that it is to make sure that you're giving the blood supply the best chance. Remove any constrictive dressings and try and identify what the cause is that is causing the neurovascular compromise. And that's something that's quick and easy to do. If someone can be doing that time that we're notifying the medical staff as well, you're getting the blood supply back into that limb as quick as possible. Keep it under close neurovascular observations, and as soon as you can, be informing the medical staff. For me, and my experience is more in the public hospital situation, and quite often we worked with quite junior interns and RMOs. If I have suspected something like a compartment syndrome, of course, out of courtesy, I would let that junior RMO know. But I think that's enough of a reason to also go straight above into the next level of registrar. And for those, obviously in the private system, letting your consultants know straight away. And, they're going to appreciate the fact that you've let them know as soon as you can for their patients. If patients have got casts on, there's a little bit of research in it, because again, that's something that we can do. A fracture that has been immobilized can always be reset at another time, even if we lose the alignment of that fracture. But neurovascular status and nerves that are damaged can't be repaired quite so quickly. So, if in doubt, still split that cast and get that blood supply back into that area. Quite often you see people and they just split down one side of the cast. And there's some research that was done back in 2004. And what they found was that only allows an average fall of the pressure of about 30% by doing that. So it's better than nothing, but we can still get the pressures down a little bit more. If we do that bilaterally, splitting both sides of the cast, then we're getting a nice 65% fall in pressure and allowing that blood to come through. But what you do see quite often is that people then don't split the padding or the web rule or whatever it is that's under the cast as well. So get a pair of scissors, cut through all of that as well, and you'll get that further fall of the 10%, and you're giving that limb the best chance to be surviving whatever is causing the pressure within that. The other thing is that the homeostasis of the patient as a whole, what we want to do is if their blood pressure is almost tensive again, we're giving the best chance for that blood supply to get into those tissues that are under threat. Making sure that, again, they're getting nice oxygenation. And again, that will depend on what is happening with the patient. Are they multi-trauma? Are they compromised hemodynamically? Anything that we can do to be maintaining their homeostasis is all going to be helping with getting the oxygenation through to those tissues. From the medical side, they will come in and measure the compartment pressures. As we say, they may choose not to, because if it's a really clear compartment syndrome and there's no doubt, then speed and getting to theatre is the priority with that. Taking them into theatre and doing a fasciotomy where a incision is made, right down, splitting the fascia and opening up that compartment and that straight away will allow that blood supply to come through. Usually they will do that bilaterally because one of the compartments on one side is the one that's compromised, will quite often be pressing on the compartment on the adjacent side. So it's much better if they can come through, for example, with the tibia, areas around the tibia, if they can do bilaterally both sides, you're going to get that release on pressure. Okay, the next slide is showing fasciotomy and also one of the bit more old-fashioned ways that we used to actually try and close a fasciotomy as well. So with those top slides, we've had the fascia open right down to the muscle, and you've got the muscle on view there. That's allowing all that blood supply to come through. When they first come back up to the ward or wherever situation that they're going into, it will remain really quite open like that as well, because it's almost like the pressure's just sort of blown that apart, even though it hasn't, it's been an incision, but as soon as they incise, it just comes right open from all of the edema and whatever is causing the pressure within that area. One of the ways, and I believe this is not quite as commonly used anymore, and I appreciate anyone making comments on what happens in their clinical areas. What we used to do was we used to have clips on either side of the wounds. We'd use what we call a bootlace, and that would be crisscrossed over, and then little by little over the next few days, while we were doing our dressings of the area, we would be bringing those opposing sides of the wound together and closing it up and making sure again that the neurovascular status was handling all of that being closed. And as you can see from the slide, little by little the appositions just come together there and they've closed up the fasciotomy. I believe what is happening a lot more now is that we have the vacuum assisted closure, that some of the clinical areas are using vacuum assisted closure on the top of the fasciotomies. Some will actually come back and might need some grafting as well. Some are leaving them open and allowing them to heal by secondary intention. Okay, so there's a few different options there for what will happen to the fasciotomy area. Has anyone dealt with fasciotomies, and what are they using within their clinical areas? I'll give just a couple of minutes to answer on that one. Yeah, mainly the vacuum assisted closure. No, it hasn't dealt with them. Yep, that's it. Okay, and again, the vacuum assisted closure and some of the others haven't seen them. Yep, and some of them have been suture closed. Look, the boot laces like that was a really, really good way of trying to close them. We'd actually have them crisscrossed across. The only problem was you get your little Mackindo forceps in there, and you'd have to, try and tighten them each day. You'd just about get them to tighten. And then because they were quite slippery with all the fluids and stuff, it'd be very easy to slip and whoosh, straight down. And then we'd be starting again to try and thread them across. And it got a really good result, but not really that easy to do. But certainly with the negative pressure dressings and all of the closure that we've got available to us, it certainly makes it a lot easier to try and manage them afterwards. But the main thing is they've got a limb that's viable, whereas if they hadn't had the fasciotomy done, there was a limb that was totally non-viable. So the priority is getting the pressure out from that area. The complications afterwards that we tend to see is infection, obviously any area that's had necrotic tissue that's forming within that area, contractures because of the nerve damage to the area. The other thing is crush syndrome, and while the muscle anoxia is happening, while muscles are being damaged, what they're doing is releasing all that myoglobin into our blood supply. The myoglobin causes the acute tubular necrosis within our renal system, and you can go into rhabdomyolysis from that as well. Obviously, nerve impairment, loss of that limb function, and if you've got a limb that's not functioning, and having all those problems, they may require amputation. And compartment syndrome is actually the most common reason for the medical malpractice suits in the US. Okay, for our orthopedic surgeons in the US, that's the most common reason that they may be sued by patients, is if they're allowed to go into compartment syndrome. Okay, so in conclusion, what we want to see is we always want to have a really high level of suspicion within our orthopedic patients and know the early signs. Don't rely on the pulselessness to make you suspicious of that. Be listening for the signs of the nerve damage, particularly the pins and needles and the pain, and that should be enough to alert us to look further into what's happening. Prevention and early detection are essential in avoiding any long-term damage to our patients. Do what you can to relieve that pressure and notify your medical staff immediately, even if it's the middle of the night, 2 o'clock in the morning. They're not going to mind a call if you're quickly picking up a compartment syndrome and making sure that something's done to save that limb for that patient. But do what you can to relieve the pressure yourself, making sure that limb's elevated, any constrictive dressings or plasters, getting them, making sure that that constriction is relieved through that area, because quite often you will cut the plaster and straight away the patient will report to you, oh goodness, that pain, that just feels so much better, because that nerve pain for them is really, really severe. And also really important to know that it only takes one shift of not picking it up and a patient can lose a limb. Okay, so thank you for having a little listen to our session on compartment syndrome. As we say, we really look forward to seeing you at the next ANZONA conference, which is in Perth in 2017. All's really well underway. We have on from Wednesday the 25th to Friday the 27th of October. Can I please do a brief cover exertional compartment syndrome? Yep, sure. Okay, off the top of my head here. What tends to happen is you've got patients that are, doing quite a lot of exercise, really quite fit. It's unlikely to happen to me. I haven't had too much of a problem with exertion, but as their muscle bulk is increasing within their compartments, the compartment is not actually getting that much bigger. But when they're exercising and they're, increasing the blood supply to that area, they can be getting the pain on exercise. And then what they need to do for those patients is they will actually, relatively rare, you've seen only one in your career. Yeah, what they will actually do is actually try and replicate what is going through within the exercise and using the striker needles to actually find out what's happening within their compartments, to be trying to find out what their compartment pressures are and seeing if they're peaking, and that's what's causing the pain for them. I believe that I think it's really quite rarely done, but I believe that some people have gone on to actually need fasciotomies done from the exercise. But the main thing that they do is that they may actually have to take a rest from the exercise or whatever it is that's causing them from the exertional compartment syndrome. The other thing they need to have is a differential diagnosis, because the pain is quite similar to, when we say shin splints. Is that a case of an exertional compartment syndrome, or is that also a case of stress fractures that are happening within that area? So again, they'll be having a look to see what's happening with all of that. But, if it is the compartment pressures, they may need to avoid whatever it is that's causing that. And I'm not sure what else they do surgically. Paul might have an idea, but I know that there has been some patients that they have required a fasciotomy for the compartment syndrome as well. But I haven't dealt that much with it because you don't tend to see them as an inpatient within a clinical area. It would probably be something that the sports doctors and the sports physicians might be involved with as well. So I hope that briefly answers your question there, Dave. Any other questions that we have from people?
Just want people asking, sorry, I might butt in.
Yeah, please do. agree.
So the exertional ones, yeah, I guess most times if you're in the acute setting, you're going to see them once they're already diagnosed, or at least while they're having investigations. So it's not as obviously as generally it's not as acute as one of the traumatic ones, but it still can be. And like Wendy was saying, some of them may go off for fasciotomies, or if it's just in terms of muscle mass and pressure, stopping that exercise for a period may do the job as well, and that might be enough. It's interesting
Yeah.
when you had the slide about the wounds before. When I first started back in the 80s, they were just packing those big long wounds with some ribbon gauze, and then they'd just sit there
Yeah, with the
for days
saline.
and days and ooze and smell, and it was really, really, really unpleasant. One thing I really like now about the negative pressure devices is some of them you can actually do washouts with them as well. So if you put that in, you can sort of leave the wound open a bit longer potentially, and do a couple of washouts every now and then to keep it nice and clean, and then sort of let that heal up under the negative pressure. And I think that's seems to be the way to go nowadays. And hopefully obviously you're
Yeah.
trying to limit infection and then prevent grafting as well. So, sorry, I'll let the other
Yeah, but
people who
those.
type questions as well have a go as well. Sorry.
No, that's right, and I agree with you on that because the negative pressure certainly, has done a lot for our orthopedic patients, and works very, very well for a lot of things that we're seeing now. We just had a comment that yeah, in the Navy, a few members had fasciotomies for exertion on compartment syndrome. It reminds me, particularly with the crush syndrome, that there was a fairly famous clip of a marathon runner that was trying very, very hard to finish his race. And what had happened was he'd gone into complete renal failure while he was still running from the rhabdomyolysis. And with that, he had the confusion, he'd lost all muscle coordination, and he was just absolutely trying his best to get over the finishing line, and he was stumbling left, right, and all over the place with medical people around him and knocking them away, and then he's pretty much collapsed over the finishing line and was in a critical condition by the time he finished. Um, that's what can happen at the absolute extreme um, from the exertional compartment syndrome when it's nothing's being done about it. But if you ever look that up, it's quite horrifying but interesting to watch at the same time. So we question, how do the medical team measure the compartment pressures? What they have is they have a needle that actually goes into, through the limb and right into inside the compartment, and it'll measure the pressure within the compartment. That's called the ones that I've been involved with have been by Stryker, and we've just called it a Stryker needle, and that's how they measure the compartment pressures. Most of your emergency departments will have some sort of measuring device to be able to do that, and probably down within the theatres as well. They'll be able to get hold of something. Okay, you think they can stop the Striker machines, but there'll be, I'm sure, another brand that they can look at to be measuring within those compartments. Jovi's asked what the best practice on frequency of neurovascular assessment in the immediate post-operative period. That's quite a difficult question to just answer off the top of my head. I'd have to have a look at that and research what they were saying. The frequency that I'm used to looking at is within half an hour for the first 2 hours. But again, it's really tailoring it to the patient so that with any level of suspicion at all, that should be increasing to a lot more frequently than that as well. And feel free if you've got different ward policies on that one to chip in, guys. Because I don't know if there is an evidence-based answer to that. Paul may know, but it's not one that I'm familiar with.
Yeah, no, I don't. I'm not aware of one because it's an interesting point, and it's important point because there's so much variation, I think, in practice in terms of how the frequency of neurovasculars. And I mean, my practice traditionally was hourly for 24 hours, but I just I thought that was ridiculous for most people. In terms of
Yeah.
my practice, I always recommended go by the patient. So if you've got someone who's completely orientated, who you can educate about the signs and symptoms, and you can rely on them to let you know pretty soon once those signs and symptoms occur, then the frequency will be much less. Now, if you've got someone who's either unconscious, like Wendy was talking about earlier in the presentation, or they have maybe dementia or an acute delirium, then I would recommend doing them more frequently, and also via the type of injury and the severity of the injury. Having said that, you need to qualify that you can still develop a compartment syndrome out of a relatively benign looking injury. So don't just dismiss those more minor injuries, I guess. But it is something we probably should do, Jovi, as a specialty group, is to come up with some guidelines around that. The UK did release some guidelines 2014, I think. But I don't think they spoke about frequency. I'd have to have another look at that. But you could also have a look on the RCN website if you're interested as well, to see if that's there.
No, that's good.
Yeah, there might be a
Yeah,
consensus.
maybe
That's
there is
probably
a consensus.
the highest
The
level of
difficult things
evidence, I
is,
suspect.
yeah, the difficulty is that the things that are the absolute bread and butter of orthopedics, almost like neurovascular assessment, almost aren't sexy enough to get the funding for research to have a little bit, what is the evidence on all of that as well. It's more around the drugs or, things that are getting the funding to be able to do that too. But certainly a conversation to get consensus is a much easier, level of evidence that we could probably aim for with neurovascular assessment. Just on the striker needles, and particularly when we talk about the exertional, if anyone's seen them, they're like the thickness of a knitting needle. Okay, so it's really uncomfortable for the patients to have it done, but obviously something that's really quite essential if we're suspecting all of it as well. And there we go, we've got a topic for Jody as well. Is there any other questions at all on compartment syndrome? I'll give people a little minute to type. No, oh, thank you very much, Joe. Great, thank you very much. I'll just check that there's no more questions. But as I said, I really hope to see you guys in Perth come up and say hello to people that I haven't met before. And, we're looking forward to an interesting conference with everybody. The ANZONA conferences are fantastic for the people that haven't been before, and we're aiming to keep that same high level with the conference. So we hope to see you there. And thanks very much. I'll close off the recording now. And we hope to see you at webinars as well, Dave. That's great. Thanks, everybody.
Thanks, Wendy. That's a really great presentation. I'm sure everyone really enjoyed that, and also for the people to listen on the recording later on as well. Just for the people online, just a reminder that you will be able to get the link to this recording and other recordings. I think this is the 13th one we've got. If you go to the ANZONA website, so www.anzona.net, and there's a webinar link there, you can click on the link to the recordings from each session, which are on YouTube. So encourage you to have a look through. There's a really broad topic, some really interesting webinars too. So if you get a chance, have a look at those. Talk to your colleagues as well about joining these sessions and listen to the recordings, and get them interested in it as well. And keep up to date with what's happening with ANZONA, and stay tuned for more webinars in the coming months. Thanks all.
Okay. Thank you, everyone.